And good morning still for the next 6 minutes here on the East Coast of the United States at Deuk Spine Institute. We're getting ready to perform our second surgery of the day. Our first patient is doing fantastic. She had 2 herniated discs in her neck, C5, 6, C6, 7. We did the anterior cervical Deuk disc repair. She's getting ready to go home soon. She is from Indianapolis. Our next patient, what we're starting on right now, he's from West Virginia. He presents with severe back pain and pain radiating down his right leg from pinched nerves. He has a lot going on in his lower back and the spine. We're only going to fix the things that are causing back pain and leg symptoms. All right. I'm going to give a little numbing medicine. That's just numbing medicine. Our patient is awake. I need his help in the beginning. Lay still. Everything's okay.
Doing great, buddy.
We're doing L2-3, L3-4, L4-5, DLDR. And then we're going to go in and treat his facet joints for Deuk plasma rhizotomy treatment for the facet joint pain that he has. All right, let's get started. He does have bad scoliosis. Shot. That looks pretty good. We're going to aim for L4-5. Numb. I'm going to give you some numbing medicine. The patient has lots going on, and it's really easy to get distracted. Lay still. He doesn't like the numbing medicine. Oh, wow, Nikki. I didn't even realize that was you. I thought it was Luis. That's how good you're doing. Lay still. Shot. All right, let's get an AP and see where we are. We're aiming for the L4-5 disc. This patient has degenerative disc disease, herniated disc, bulging disc, ruptured disc, protruded disc, extruded disc, and everything in between. And he has scoliosis too. You guys see that? We're not going to fix his scoliosis. Our goal is to get rid of his back pain, and we don't need to fix the scoliosis to do that. Lay still. Lay still. Shot. He's not going to like this, unfortunately. Lay still. Shot. You're doing great. Don't move. Any help you can give me. Shot. All right, let's get, I feel I'm going around the spine, which is good. AP. Shot. AP. And we're okay right now, not too much. All right, good. You can see the giant facet joint there. You guys see the facet joint? Show us the facet.
Yes, we do.
I may have to start a little higher and aim down a little lower to get around that facet, but that's a pretty bad facet. All right. Shot. All right, let's hope we can get there. Lay still. Shot. Shot. I actually feel the herniation. AP. Show us the facet arthritis there on the lateral first. Sanjay, take a look at the x-ray. Look at all that black stuff. That is thickened bone. That's arthritis, and we call it facet hypertrophy arthropathy. Whose phone is ringing?
It's yours, doctor.
Oh, okay. No problem. That's my phone in the conference room. All right. Now the facet joint is forcing me really lateral. Let's see if I can get in the right position here. Shot. Shot. Yeah. Look at that. That's fascinating, isn't it? I think that's the herniation. Shot. AP. So we have the very best x-ray machines in the world. They're Siemens. They cost a fortune, but they are the best. That's actually really good. We're in. All right, we're in the disc space. Thank God. We made it. Okay. I'm going to try to get the next one through the same incision, but I have a bad feeling I'm going to have to try a different entry point. The entry point, folks, is where I go in. And I don't know that I can get the next disc in the same entry point. So let's go with another needle. I'm not going to make an incision. I'm going to just take a needle. All right, let's go for 3-4. Now, Sanjay, do me a favor and show our audience why is it that patients get so much pain in their back from the actual herniated disc? What is it about the herniation?
Done.
All right, there it is. Okay, welcome back, Shot. We are now trying to get to the next disc, which is the number 3-4 Shot. And I'm literally getting caught up on the facet joint. I'm going to go around it if I can. Shot. Trying to get around it, but it's hard. I'm hitting bone. And you can see the facet joint itself is actually, there we go, quite arthritic. Shot. I hope I'm not getting deflected. Ideally, you want to hug the facet to get to the disc. Shot. All right, let's go AP. So we're almost there. Do we have any questions?
No questions.
So this patient, we're treating his back pain and we're treating his leg symptoms, which is pain and weakness, numbness down the right leg. And the source of the back pain are two things, the discs that we're fixing as well as the facet joints. All right, almost there.
What is a scoliosis?
Scoliosis is twisting of your spine. Shot. Let's take an AP.
Is that visible in the X-ray?
Yes, take a look at the X-ray. You can't see it on the lateral view. You can see it on the front view. Jordan will show you right now. Shot. All right, so we are probably getting forced outside the disc. There's the curvature. Just show them the curve. Uh-huh. The whole spine is curving. Go around the left side of the spine. You guys see that? How it's going all the way out there and then coming back.
Yes.
All right, I need a little bit of dye. Stay there. Let's just test this and see if we're in the disc. Shot? All right, we're in the disc, thank God. Okay, good. Is he sleepy?
Yes.
Good. So we are in the disc.
We're going to do one more, right?
Oh, yeah, yeah. I just want to make sure we're in the disc, but we're barely in the disc. We're there, though. All right, we got one more to get. This is going to be 2-3. I'm going to do a whole new location for 2-3. I'm going to go up a little higher. So there'll be two incisions here. You see the peau d'orange? The orange peel?
Need a lot of arches.
Dr. Berndes likes the orange peel. Shot? All right. looks interesting. I need to see a little bit behind the spine. I think your x-ray is not proper. Shot? That's better. Okay. I've got to sneak around the facet as I have already. Shot? Man. Shot? 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 It's very important to use the facet as a landmark for this procedure. AP? The reason is that the facet is everything in this procedure. You want to know where it is with the tip of your needle. You want to touch it and you want to go around it. Ugh, that is so bad. See that? Amazing how bad that is. So bad. Jordan, try to get a picture like that, a true AP. Yeah, you see the curvature there?
Yes, I do.
Mm-hmm. That gives you a better idea of just how curved the spine is. It shoots off to the left and then it comes back to the right. That's scoliosis. We're not here to fix that. All right, let's go back to a lateral. Thank you, Jordan. Can you scroll his MRI for me? Do you know how to do that?
Up and down.
There you go. She's got it. And the other way?
No, no, no.
No, you keep rolling. Just roll your mouse the other direction. Yep, and now the other way? Okay, so it's pretty bad at 2-3. All right. Well, I feel the facet. Shot. I need to get around it. There we go. Shot. Okay. I'm hitting just outside his disc. Shot. All right, so I got to try to redirect. Go a little bit higher. Shot. Uh-huh. Just got so much bone spur around the facet right here. There we go. Shot. I think we're... Yeah, it keeps pushing me down. Pushing me south. Shot. All right, that's the best I can do right there. Give me an AP. I'll be able to get it later. We'll make that our last one. All right, we're ready for him to be awake, I think. Yeah, look how bad that is. All right, very good. I'm happy with that.
How
So
you
it's,
doing, my friend? You all right?
yeah, not the top one.
How are you doing? A little sleepy in there? Snug as a bug?
Num num. So we've literally lost 2 drops of blood. I'm going to give him some more numbing medicine. Because we're about to make our incision in a few minutes. So just to keep things simple, he has 3 discs that are causing his back pain. And he's got facet joints, which we're going to be treating later. You have the L4-5, the L3-4, and the L2-3. How is he?
Thank you.
Anything? Because we don't have to do the discogram.
How you doing?
Are you awake?
Yeah,
Yeah.
there he goes.
You having any pain?
Anything bothering you right now? You having any pain? Did you just say yes or no? I can't hear you.
Shot? All right.
I don't think he's having any pain.
Well, I think he's a little sleepy. But it's okay, because I don't need the discogram per se. All right, let's get started. I mean, I need the chromodiscogram. I don't need the evocative part. So I'm happy not having the evocative part.
Stylus?
No, guide wire.
You want to go? We're going to stay put?
Go ahead. We're going to start with this upper disc. Shot. 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 All right. So we're going to make our incision. I'm going to take this out. Shot. On a scale of 1 to 10, Sean, this is going to be about a 9.5 in terms of difficulty. But this poor man is suffering. We're good. I mean, he's not moving at all, so you can keep him lighter if you want. No problem. Num num.
I think it's all the
Huh?
I think it's all
Happy to do it. But what I'm saying is he's doing really good. He's real comfortable, and so you don't have to make him too deep. Shot? All right, what videos have we shown? Have we shown how the Deuk laser disc repair actually works? I don't think so, right?
No, we just showed
Shot?
them the back pain.
Uh-huh. Well, let's show them how this surgery works. Because it's only going to be for a minute. All right, welcome back. You can see how this procedure works to clean out the annular tear, remove the herniation, but most important, we're debriding the tear in the back of the disc where all the pain comes from. All right, let's get an AP. Yeah, we're almost done with the stimulation. Yeah. You can see the guide wire goes across the disc space, which is good. All right. Yep. So let's keep going. I'm going to keep using my guide wire because I believe it's in a good location. Let me know when you're ready. And I'm trying to angle my instrument so I can get into his disc properly. Good. And yeah, we can take that. Good. It's always hard when you're dealing with scoliosis because the spine is so twisted and you have to really aim across to the other side when you're on the short curve, basically. What short curve means is you're on the inside of the curve. All right, why am I not seeing my marker? Would you get rid of these? There. Do you not understand that? I cannot see. There's the marker. It's getting a little faded. Uh-huh. All right. So this is stimulating for the patient. He doesn't like it because we're working right near the very pain areas. Take that. Take that. We're inside his disc at L3-4.
Doesn't the numbing medicine numb the area completely?
No, numbing medicine does not numb the area completely. It helps, but it doesn't numb the area completely.
Keeps anesthesiologist.
There is no numbing medicine that completely numbs everything. All right, it's very dark inside the disc, but I can see pieces of disc right there. I think, huh?
I'm just glad my endodontist didn't tell me that.
What?
I had headphones on.
Oh, really? That the numbing medicine doesn't completely numb? All right, we are inside the disc. Laser?
I brought my own headphones.
There's a lot of dye. And
We have a question from Charles on YouTube.
where's my irrigation? Yeah, we'll take it.
If unable to complete the technique using DLDR, do you proceed to an open surgery,
No.
or is the procedure aborted and other options explored at another time?
That's correct. That's correct. We never transition from one surgery into another. We always have the patient wake up and then decide what they want to do. Yep, that's the right thing to do. I'm not sure of any doctor that would just go into another surgery, at least not in our country. Now, there are surgeons that, you know, they may end up operating on the wrong area, and then they wake the patient up and say, oh, we had to do more work than we thought. But what they're really saying is, usually what they're really saying is, I made a mistake. I did the wrong area. Is this the right hertz? It seems fast, but it could be. All right. Great. Thank you. Watch these. Luis, watch these needles. I don't want them pulling out as I manipulate what I'm doing here. You understand? Yeah, we never just open somebody up after we plan to do this surgery. We don't just go and open them up if we can't do it. I don't do anything I haven't really discussed with the patient in advance. That's what informed consent is about. So you can see the tear in the disc. It's pretty significant. You guys see it?
Yes, we
That
do.
big crack right there?
Yes, we do.
That is the tear. The annular tear. You saw the video. And this will heal in time. Let's get the grabber. Laser off. So I'm trying to grab out any pieces of loose herniation that I can find with the grabber. Sometimes you get lucky. You get a few pieces like that one right there. How's he doing? Good. But this is the surgery. It's just kind of going back and forth between the laser and the grabbers. Most of the surgery is done with the laser. You could see there was a lot of the blue dye, and as a result, when we first came into the disc, it was coming out through the tube and it was obscuring our vision. That's gotten better now. What is it? What's wrong?
No, nothing's wrong. Specimen parameters to set up properly.
I don't really see a lot of herniation left. All right, any other questions? We're almost done with this disc.
Yes, we have a question from Jocelyn on
Uh-huh.
YouTube.
Sure.
With more difficult surgeries like this, is there a more difficult recovery or more pain?
No. The patients don't experience anything difficult with the surgery. I do, and the anesthesiologist does. But the patients, to them, the experience is pretty much the same. There's really no significant difference in the recovery.
We
Yeah.
have a question from Oz on YouTube.
Sure.
Doctor, I have seen some MRI reports come back and literally say normal or normal disc. And some surgeons still recommend surgery. What do you think of that?
I think it's a great point, and I'm glad you brought it up because the radiologists call things normal all the time when they're not really normal. I don't necessarily blame the surgeons. I think they're probably seeing things the radiologist left out of their report. The radiologists really, unfortunately, are unreliable. You can't really rely on their report, okay? Some of them are very good, but only about 10%. The other 90%, you can't trust their report. I would trust the opinion of a surgeon more than I would trust the opinion of a radiologist. Radiologists are not clinicians. Clinicians are doctors who treat diseases. They treat, okay? Radiologists don't treat. Some of them go on to learn how to do interventional radiology, or they'll do pain management or something else, but the radiologists that read reports of MRIs, they don't treat patients. So they have no clue what really causes symptoms and what doesn't cause symptoms, okay? The surgeon does. The surgeon knows. Now, it doesn't mean I trust all spine surgeons, because I don't. But I trust Deuk Spine Institute. So if you want to know an honest opinion, you send your MRI to Deuk Spine and you do an MRI review. Now, I'm going to tell you something. I can't look at your MRI or your MRI report and decide if you need surgery or not. I actually have to see you, the patient. I've got to see, where is your pain coming from? Is it coming from the disc? Is it coming from the facet? Right? But, yeah, I don't really give much credence to the radiology report except to look for anything like a tumor or a fracture or an infection. Then I get more concerned. So, in my opinion, you need a clinician to tell you why you're having your symptoms. A radiologist will never be able to do that. Unless, of course, they're a clinical radiologist, which very few are. I hope that answers your question. But if you want to know the God's honest truth, send your MRI to Deuk Spine. Let me look at it, and I'll tell you exactly why you're having your pain. And I don't do it based on your MRI, by the way, for those of you who have done my MRI review. I do it based on where your symptoms are coming from. The MRI is just helpful, but it certainly will not tell you where pain comes from. So, only the patient can tell a doctor where the pain comes from. That's why we do a Zoom. I need to hear from the patient where their symptoms are. Sometimes I even do a quick exam with the patient right there. All right, 1 minute left on this disc.
We have a question from Dune Star Design on YouTube.
Sure.
You check with the patient where their pain is before putting them out with anesthesia?
Yes.
If you do have multiple levels, how do you do this? Do you wake them up again?
No. We test them one level at a time. We test them one level at a time. So we do the injection, we monitor the patient for the response to pain, and then after we've documented it, we wait for the pain to go away, and then we do another injection of a separate disc, and each time we inject the disc, we monitor the patient for their response. So you can test multiple discs with one discogram. You have to have multiple needles in multiple positions to do that. That's what we did. Now in this patient, we really didn't do the discogram. We did the discogram, but not the evocative discogram that we normally do. And the reason is that he's doesn't tolerate the pain well, and he moves around a lot. So we wanted to just get him asleep and get the surgery done. We're not really doing the surgery for the pain right now. We know these discs are causing his pain in the facet joints as well, based on his clinical exam. So I needed the discogram done so I could see the tear, see the herniated discs. They usually will stain blue. He's a more challenging case, so I'm more focused on just getting his surgery done than really mucking around with the discogram right now. What's up with the camera? You see that? Grab her. All right. It's just got some flickering going on. You think that's the tower? Huh? Camera? This one right here? All right. Take it. Almost done. There's the end right there.
Does the patient's age have anything to do with the time that they take to recover?
Does the patient's age have anything to do with the time that they take to recover? Recover from the anesthesia or recover from the surgery?
The outcome of the surgery.
I don't think the age has anything to do with it. I think that they have other medical factors like nutritional status and how deconditioned they are, and you know how much support they have at home to help care for them. I think those are more important factors than age. We have lots of people that are older and they recover very fast. So I'm not concerned about age. The recovery has everything to do with nutritional status, other medical issues. What's the heart? What's the hemoglobin? The red blood cell count? Do they have any other things happening like infection going on somewhere? Do they have good support at home to help them? Did the surgery go well? Did the surgeon do a good job? Did they screw up? Is there a lot of bleeding, a lot of trauma to the tissues? A lot of it has to do with the surgeon, to be honest, and how the surgeon does the surgery. Does he do a good job? Did they make mistakes? Did they hurt the patient during surgery? So there's so many variables, but age is not, in my opinion, it's not important. I think older people a lot of times recover faster than younger people for various reasons. Maybe they're just, what do you call it? Darwinian stuff? Survival of the fittest. They've made it this far, and
Maybe they don't rush to go to the gym or carry everything.
Behaviorally, they probably are at an advantage over young people. Younger people have more to learn. Take my son. He's 18. He argues with me all the time. He doesn't listen to wisdom and experience because he knows more than me, at least in his mind.
How does he like it up there?
He loves Princeton. He's doing good. He's back now for the week, but trying to get him to come in, have his ankle looked at. He doesn't listen. We're done here. Any other questions?
We have a question from Dune Star Design. Do you still have the Deuk warranty?
The Deuk warranty, yes, we do. We have the Deuk spine guarantee. What that is we guarantee the results of the surgery are going to meet the patient's satisfaction, or we will continue to treat them until everything is exhausted. And the warranty requires that the payment for the surgery is the full charge, and the payment for the surgeon is the full charge, and the payment for the anesthesiologist is the full charge. I think we've had just a couple of people do the warranty, and it's going to be hundreds of thousands of dollars. So most people don't want to pay that full amount themselves. But the Deuk spine warranty means you basically pay full price for your surgery, and then we guarantee it for a year, or we could even go longer terms. So if the patient reherniates, for example, we would fix it again at no cost to them. Even if it's their fault and they did something they weren't supposed to, we would still bring them back and do the surgery again at no cost to them. But you have to pay the full price. That's the key. And everybody I know gets a discount. So if you want the guarantee, ask the representative what the full price is, and you can get the guarantee. It has to be done in advance of the surgery. Again, it's not a money-back guarantee. We would never offer a money-back guarantee because patients would just say they're still having pain to get their money back. But we offer a guarantee where we'll continue to treat the patient at no cost to them until we've done everything that can be done. So, and they won't have to pay out of pocket for that. Nobody else in the world offers that guarantee. We were the first to offer it. I think we started offering it back in 2014, 10 years ago.
We have a question from Dune Star Design on YouTube. Saw a study that manipulating the annulus by creating a tear increases degeneration threefold. Does this create an additional annular tear on insertion and moving the dilator around?
Great question. No, we are going through the annular tear with this surgery. So the tear is already there. The herniation is already there. We're literally passing through the herniation and the tear to do the surgery. That's the beauty of the surgery, is we're not creating any more damage to the body. We're actually going through an old injury, the injury we're there to fix.
We have another question from Dune Star Design. When the laser sparks, does that mean you are hitting the bone?
Yes. Yes, the laser will spark if you hit, it's not sparking, but it creates a flash. It's not like a spark, an ember or something. But that happens when you hit something that has metal in it. And remember, bone has metal, right? It has calcium. And calcium is a metal ion. I'm not sure. I think that's it. But let's see. It's really hard to see those laser etchings. Why is the irrigation so weak and pathetic? Oh. Okay, you guys got to put this on properly. That's you, Nikki. And you can't have kinks in the tube. Okay. All right.
We have a question from Dune Star Design. If
Sure.
you are calcium deficient, would you...
I can't understand some of your words there, Sanjay.
if you are calcium deficient,
Calcium deficient.
would you tend to have more bone spurs?
No. No, calcium deficiency has nothing to do with bone spurs. Bone spurs come from abnormal stress and inflammation around joints. Nothing to do with calcium. They're made from calcium, but regulating your body's calcium has nothing to do with bone spurs. We see people with osteoporosis who have bone spurs, and they don't have enough calcium in their bone. All right, we're working on the L4-5 herniation. You can see this disc has more of the disc material, the blue stuff, the herniation, degenerated disc. It has just more substance of the disc itself. That's the tear. Just to where the laser is right now, you see the crack, that's the tear, the annular tear. That's what we're here to debride. You see the herniation stuck in the tear. I'm going to twist my tube a little bit to the left, which is down towards the feet, and then I'll twist it a little bit to the right in a moment.
We have a comment from Oz on YouTube.
Sure.
Doctor, a 2018 study was published stating that epidural injections are causing paralysis. Do you agree with this?
Epidural injections are causing paralysis?
Yes, that's correct.
You know, it can happen, yeah, of course. We've published videos on our YouTube channel showing that. And it can happen. If the doctor who puts the needle in puts it into the spinal cord accidentally, the patient will be paralyzed. It's happened many times, not here at Deuk Spine, but by other pain management doctors who are not very good doctors, but there's lots of them out there, so you have to be careful where you go for your epidural. I don't believe in epidural steroid injections as a treatment for pain because they don't work and they don't last. Patients have to keep coming back. And to me, that's not a treatment. When you have a treatment that actually cures pain, like the Deuk laser disc repair, I don't see why you would want to do a treatment that doesn't last or doesn't work very well. So, but that said, many doctors recommend epidural steroid injection. I just think that that's a treatment that should be almost eliminated completely. Maybe do the epidural if you have, say you have a recommendation for the surgery, you have to wait a few months because of your schedule or whatever the reasons are, and you need immediate relief, then you do the epidural to bridge you and your symptoms until your surgery, which will fix the problem. Are you taking off your x-ray gown? All right, we're almost done with the L4-5. The last one we're going to do is L2-3. Then we're going to move into the DPRs. So Sanjay, I want you to end the DLDR and go into a lumbar DPR. Okay?
Copy that.
And that way we'll have another live stream, you know, for Henry to put on the, or you if you're the one doing it on YouTube. I want you to put it under the lumbar Deuk plasma rhizotomy channel.
Copy that.
So this first segment will go under the DLDR channel live stream. Actually, they all go under our live stream, but this will go under the DLDR live stream, and the next one will go under the DPR live stream.
Copy that.
Thank you.
We ha-
Almost done.
We have a question from Bali. on Facebook.
Uh-huh.
Can we get rid of bone spurs by taking some medicine or supplements?
You don't need to get rid of bone spurs. Okay, bone spurs do not cause problems. That's basically a big lie and a myth that you guys are all like sheep believing that bone spurs are the problem. Bone spurs are not the problem. Bone spurs cause back pain as much as wrinkles cause back pain. Just remember that. The surgeons want you to see bone spurs so that you have to have surgery in your mind, because nothing else will take care of your bone spur. But it's a lie. You see, Sanjay, how many people believe that nonsense?
Yes, I could see that.
It's a big question. We always get the same question over and over again.
Yes, we do.
Bone spurs aren't normal, but wrinkles aren't normal either. Bone spurs and wrinkles are the same. They both cause back pain equally. So, if you want me to get rid of your bone spurs, come. I'll get rid of your wrinkles and your bone spurs. And your back pain will be the same. It won't be any better.
We have a question from Dune Star Design on YouTube.
Yep.
Are you creating an annular tear through the front of the disc in the neck by entering? And how is it different from the trauma in the back?
Great question. So we're not creating an annular tear. We're spreading the fibers of the annulus. We don't actually tear them. So they go back together. And how is it different than trauma in the back?
Yes.
Because we're not doing trauma to the annulus. All right, just about done. You can see the epidural space. About a minute left on this disc. You can see some of the fat right there behind the disc. Some blood vessels. And this is the last of the herniation and tear. You can see the end plates.
We have a comment from Dune Star Design.
Uh-huh.
Some of those fibers look wispy and some look flaky. What is the difference?
Some of the fibers look,
Wispy
ah,
and some look flaky.
well, see all this white stuff here? These are fibers, but they're scarred. That's why they look like they're stuck together, because they are. They're stuck together with scar tissue. So that's your scarred fibers, okay, from chronic inflammation from the herniation stuck in the tear. Then you have your wispy fibers, which are not scarred, like this one right here, right? They have minimal scar tissue. They're more normal. That's fat right there. And we're just about done. Maybe a few seconds left. But all the herniation is gone. A little bit of scar tissue here. And that's it. That's it. Very nice. All right, we're taking the scope out. We're done with 2 out of 3. 1 more to go. And then we're going to move on to the DPR. The heck?
We have a comment from Dune Star Design on
Sure.
YouTube. If the bone spurs are growing into the foramen and pinching the nerve, isn't that the issue for nerve weakness?
No. Nope, it rarely ever happens. You're correct, there are bone spurs. You are correct. They grow into the foramen. but they never really cause weakness. They would have to get much bigger. What causes weakness is the herniation, the herniated disc. We fix the weakness with the surgery. We don't remove the bone spurs. So how is that possible that the weakness goes away but the bone spurs are still there? The answer is obvious. The bone spurs are not the cause of weakness. But the surgeons want you to believe that, because then you'll accept their surgery recommendation and get it done. You'll have your fusion or artificial disc. And they'll have their money. And then you'll have metal in your neck and all the complications and problems from it.
We have a question from Premier Media Group on YouTube. Could a sneeze possibly cause reherniation?
Could what?
Could a sneeze?
Yes. Yes, a sneeze can definitely cause reherniation. Yep. Shot. I've seen it happen. I have had several patients sneeze and reherniate. No, in the neck and the back. Mostly the neck. Yeah, I've seen it in the neck. We've had a couple of people like that had our surgery, and then they were not wearing the collar. Jordan, I got to be able to see up there. I think you're a little too low, right? Shot. Okay, I'm keeping my guide wire anchored on the back of the disc, and I'm running the dilator down. Shot. And I'm going to have to angle the dilator up just a little bit to get into that disc. Shot. I'm up against the herniation right now. I feel it. I'm pushing on the herniation. It's in the foramen. Shot. Hold this down. No. Hold the guy. No. Let go. Push it down like this. Not too hard that it bows, but just enough so it doesn't come off the bone. Shot. Shot. Wow. Ugh. Man, that's tough. That's all scar tissue. All right, shot. All right. Let's take the guide wire out. Mallet. Ready? Go. Shot. Shot. See how it's opening the disc space? Not easy. Very, very hard to do. Shot. Phew. Hold on. Let me get the dilator in a little bit. A little further. All right, now. Shot. Good. Okay, so we're in at 5, 4, 3, 2. Shot. That should be almost it. Yeah, good. We're done. So remember, for these herniated discs, my main goal is to unpinch the nerve. It's right there. Okay, because the nerves are getting pinched. The nerves going down his right leg are getting pinched at these 3 discs within the lateral recess of the neural foramen, which is to the side of on the side of the spine. So it's not really back pain with these discs. It's more leg symptoms that I'm targeting. So that's why the discogram wasn't as important. The facet joints are the main cause of his back pain. But I had to get rid of the herniations here. All right, keep the questions coming. Our patient is from West Virginia. He's here with his lovely daughter. She's watching his surgery right now with us. I believe. And I'm excited for him. There's a piece of herniation. Look how smooth it is. That's like a river rock. Okay, it's been acted on by inflammation for years, and it's now totally scarred and smooth. Okay, and I gotta take the whole scope out to get it off because it's so hard. That's like a herniation probably 30 years old, at least. All right. Again, you see the difference here. The disc has no jelly left. It's gone. You can just see the deep crack. And that's okay. Everyone thinks you need jelly. You don't. The jelly or nucleus is something that's needed only for your embryological development when you're in utero. It allows your entire body to form from a very early stage in the first trimester, where you're basically just a ball of cells that start to flatten out. And the notochord is a very important cluster of tissue that runs along the entire neuropore or axis, and it causes the differentiation of germ cells, which you guys know as stem cells, into the 3 germ layers, which are the endoderm, mesoderm, ectoderm, turn into everything in your body, basically, from your skin, your muscle, your bones, everything. Then at the end of that process of basically directing other cells to turn into things, the notochord becomes your nucleus pulposus inside the middle of your disc. And it just becomes a cushion, a hydraulic cushion. But then when you get a herniation and it squeezes out, it interacts with your inflammatory system, which hasn't seen it ever, because your inflammatory system is part of an adult. It's not part of an embryo. So your inflammatory system recognizes the old notochord, aka nucleus pulposus, as foreign and attacks it. It attacks it with massive inflammation, trying to get rid of it. It sees it as an invader. Your inflammatory system is not smart enough to know that it's not an invader, that it's part of your body. So it attacks it and creates inflammation. And that inflammation is where back pain and leg pain come from. The most common reason people go to the doctor, and we figured it out at Deuk Spine. I figured it out years ago. We've been talking about it, we've published it in the medical literature, and now we're educating people on it so they can understand it. But that said, people ask me, do you need the jelly? No, you don't. This guy has 0 jelly. You can see it. There's none left. And he's going to have no back pain in his spine when we're done. And it's going to stay that way the rest of his life. Even if he lived 200 years, it would still be no back pain, because we're getting rid of it with what I'm doing right here. Grab her. All right, questions? Almost done.
We have a question from Dune Star Design.
Uh-huh.
Does the dilator damage the integrity?
So tired of these questions.
Does the dilator damage the integrity of the end plates in very tight spaces?
No. The dilator does no damage. Okay, I'll repeat it again. There's nothing we do in this entire surgery that damages any part of the body except for the skin incision. That is the only damage, the small 7 millimeter skin incision. When you have laminectomy, the surgeon is destroying your muscles, destroying them, destroying your blood vessels, creating massive scar tissue, destroying the bones of your spine that are normal, called the lamina. You're supposed to have them. Destroying the ligaments, the supraspinous, interspinous, ligamenta flavum, destroying your body, destroying it. And you guys want to know if this surgery that doesn't destroy anything is destroying? It doesn't. It doesn't. Regular surgeries, the microdiscectomy, laminectomy, they destroy your body. So many places. Kind of like Russia destroying Ukraine right now. There's so much destruction, it's not limited to one city, it's all over the place. The surgeon that does your laminectomy or discectomy, they are destroying so many places in your body. And this surgery destroys nothing but makes a cut on your skin. So you should be worried about those surgeries destroying, not this surgery. This surgery does 0 damage and 0 destruction.
We have a comment from Dune Star Design.
Uh-huh.
When the annulus closes up, will the disc be able to close fully
Yes.
and rehydrate?
Yeah. No. The disc will never rehydrate. Yeah. So the annulus will close now that I've cleaned the herniations out, like this piece right here. You see those herniations right there? They're coming out. They were blocking the annulus from healing. Now they're gone. Okay, I'm going to take a few more. Your annulus, this annulus will heal. But it's only going to heal where I'm operating, right? There are other annular tears that are not going to heal because we're not operating on them. Only the ones we operate on will heal. Now, do we need to operate on all the annular tears? No. Because those other annular tears, they're not causing any problem for the patient. They're causing 0 symptoms, 0 symptoms. So we don't operate on things that don't cause symptoms. That's unnecessary surgery. Don't hit the scope. Yeah, we don't do unnecessary surgery. We do surgeries that help people. And so we're not going to fix all the annular tears. For every annular tear we're fixing, there's 10 more we're not fixing. But they don't cause symptoms. We leave them alone. You people are all brainwashed to believe surgery is being done for structural abnormalities seen on the MRI. It's not. We do surgery for physiological abnormalities. You don't see physiological abnormalities on an MRI. An MRI will guide us, but you guys are all leading to believe that the MRI tells you where to operate. It doesn't. Somebody like me, an expert in the world, will tell you where to operate. That's why we have such good results. Results that nobody else in the world has. Other surgeons will use the MRI and they'll make mistakes. They'll operate on things that shouldn't be operated on. And the patients don't do well. That's why the patients still have pain. That's why you have all these people in the world that have back surgery and they're still having pain. Because the surgeon used the MRI rather than their brain to figure out where the problem is. They don't even examine. And I was guilty of the same thing for a long time. Because, hold on, because I was taught the MRI is what you look at. You're looking for listhesis, scoliosis, kyphosis, stenosis, all that crap you're taught to operate on when you don't need to be operating on it because it's not the cause of the patient's symptoms. Yeah, we're almost done. Now, so why don't you end the DLDR stream
Copy that.
and go ahead and start the DPR stream.
Copy that. Ending broadcast in 3,